Welcome once again to our bi-weekly Friday meets. I thank all the participants for sending their cases, the panelists for joining in, and the attendees for also attending these sessions regularly. So we have 8 new cases today, one follow-up case. We'll be discussing brief clinical imaging, phenotype, and differential diagnosis for each case, which is not proven. We'll stick to 10 to 12 minutes for each case, and if it goes over that, we'll deal the case in the chat so that we can stick to the time. We'll start off with our first case, and hopefully Prituja is there and she can present the case.
Good evening, everyone. This
Yep.
is a 1-year-old male child born to consanguineous parents with history of global developmental delay, and child had seizures in the form of epileptic spasms that was noted. On examination, there was microcephaly with head circumference of 43 centimeter. There was central hypotonia, hip adductor spasticity was noted. Sorry, TMS was done, that was normal. Uric organic acid chromatography was normal. Vera test showed normal hearing sensitivity, and EEG was suggestive of hips arrhythmic pattern. And we went forward and did a MRI in this case.
All right. So MRI at the age of, I think the child was 1 year, 1 month, 1 year, 2 months of age, and have the T2 axials on top over there. And you can appreciate that there is some degree of delayed myelination, especially in the subcortical deep white matter in the posterior hemisphere, which should be myelinated by now on the T2 weighted sequences. The globus pallidi also slightly hyperintense. And also coming on top, you can see that the paracentral white matter also is demonstrating some degree of hyperintensities, some degree of delayed myelination. The brainstem also demonstrates these T2 hyperintensities. Coming inferiorly, if you look at the central tegmental tracts, they're also demonstrating some hyperintense changes. Dentate nucleus is also abnormally hyperintense. In terms of volume, there is mild degree of cortical reduction in the supratemporal brain, significant atrophy of the corpus callosum. Brainstem also demonstrates some degree of hypoplasia. The vermis and the cerebral hemispheres do not demonstrate any atrophic changes or hypoplastic changes. So on the T2-weighted sequences, this is what we could appreciate. On the diffusion-weighted scans, the central tegmental tracts were demonstrating mild areas of restricted diffusion, whereas the other abnormalities did not demonstrate any significant changes. Mild changes again in the dentate nucleus out there, the globus pallidi, but these did not demonstrate any reversal on the ADC sequences. Spectroscopy was done, placed in the globus pallidi, could not appreciate any significant peaks, no lactate out there, and there's a minor peak over there around 2.2 to 2.3, but I could not appreciate the significance of that peak. Then we thought about spectrum of disorders, focusing on the structures involved in dentate nucleus. We have all gamut of abnormalities. Looking at the diffusion changes, we thought of possible inborn error of metabolism, mitochondrial disorders, which can present with dentate nucleus changes and associated brainstem abnormalities. Looking at the globus pallidus, again, thinking of metabolic disorders. So we put in differentials of organic acidureas, channelopathies, mitochondrial disorders, though the lactate wasn't elevated. TMS was normal. Then I think this child was sent for genetics. Prithika, if you can just tell us in brief the results.
So the child was born to consanguineous parents. So there is an autosomal recessive inheritance that is seen with the gene mutation of SLC1A4 at exon 5, and it is a homozygous variant. So it's likely pathogenic since there is a phenotypic match also. And the parents were both heterozygous and asymptomatic. So this is a phenotypic match for the child of SLC1A4.
Then we looked at literature, seeing if there any imaging match. We found that the corpus callosum abnormality, the brainstem abnormality, and also the supratemporal atrophy with some degree of myelination abnormality was seen in this case, which is similar to our case. Few other examples demonstrated the common findings of some degree of supratemporal atrophy, corpus callosum abnormalities again out there. And again, the lower panel demonstrates the atrophy, and again, some corpus callosum abnormalities and brainstem abnormalities. A review of literature, we found, I could appreciate that the main MRI findings or neuroimaging findings was brain atrophy, some degree of myelination abnormalities, thinning of the corpus callosum, and also some brainstem abnormalities. Microcephaly was present in all of the cases, and seizures also had some degree of seizures such as infernal spasms, myoclonic seizures. So I think, clinically there was a match, and radiologically I also think maybe it's a match. So I just wanted to open this case. If anyone has similar experience with this gene and the treatment and prognosis for the same. This is the gene that is the SLC1A4. So primarily a solute carrier gene, and the imaging findings were delayed myelination, atrophy, some central hyperintense changes.
Is the patient on medication with vigabatrin?
No, I didn't. He is not. We checked that. We checked East syndrome too, which can have these abnormalities, but no, the child wasn't on vigabatrin. And I could find only, I think, 4 cases with imaging findings. So since I think the genetic is a match as per Pituita, some imaging.
Phenotypically as well as radiologically, it is a match because the radiological findings in SLC1A4 mutation shows thin corpus callosum with white matter abnormalities, with myelination defects and cerebral atrophy. And phenotypically, it is autosomal recessive conditions having microcephaly, hypotonia, developmental delay, seizures, which the child also has. So there was a phenotypic match with the mutation.
Is the corticospinal tract on GRE normal? Because somehow the midbrain cerebral peduncle, the pons corticospinal tract looks played like you see in ARCAS, you know, and the flick looks so dark. Flick looks really dark.
There is no GRE here. This is all T2s, Dr. Vivek.
Okay. Yeah, so there is no GRE, right?
No, there's no GRE.
No, I'm saying, is there a GRE? Yeah, there is no GRE.
No, there is a GRE, but there's nothing on the GRE. I haven't put it
up. There's nothing on GRE because in the pons also.
I think that is the myelination. Some areas are myelinated and some are not. So maybe that is the differential which you're seeing. Similar to the flicks, the global cell is slightly hyperintense, so giving a relatively darker appearance on.
I think very young children, this appearance can be normally seen. So it should not be mistaken for Ersatz. So very young children are you'll tend to diagnose Ersatz if you look at this finding, because most often you can see this finding. This is a myelination picking up.
Right.
Yeah. I think at the point of Ersatz also there should be some superior atrophy, vermin atrophy. So yeah, though variable, but yeah, should be expected. Yeah, Dr. Mankad, sorry.
Oh no, I was just saying Ersatz seems to have big pons. I don't know if you all have noticed.
Yeah. I've seen your tweet, and the diffusion DTAs can pick up.
And the pons are really big for some reason.
But Ersatz would not be compatible with this clinical presentation.
No.
I would not.
This child doesn't have ARCAX.
I'm not saying 1 second about this differential diagnosis.
Yeah, no, I'm not saying it is. I'm just saying the pons that looks like it. It's not obvious.
Yeah. Got it. All right. I just wanted to show this case. This was the first time I have seen this case. Yeah. All right. To our next case, Pituja, over to you.
Yeah, the next case, she's a 7-month-old female child born to non-consanguineous parents with no postnatal complication. And then she presented with history of moderate grade intermittent fever for 5 days prior to presentation. Associated with this, she also had developed dull activity, decreased feeding, along with decreased urine output. So on day 4 of illness, she had multiple episodes of seizure, which was controlled with loading multiple anti-seizure medication, and the child had to be intubated for the same. When she presented to us, she was intubated. Her pupils were 3 mm bilateral reactive, and there was increased tone on lower limbs as compared to the upper limbs. DTR was elicitable, and flexor plantar response was seen. We did basic investigations. Apart from then, we went ahead and did a MRI brain for this child.
Right. So I have the diffusion and ADC sequences. You can appreciate extensive diffusion abnormalities in the bilateral hemispheres. It almost looks like a large ICA territory infarct on the left side. Multifocal abnormalities in the deep brain nuclei, particularly on the right side, and again subcortical cortical abnormalities along the frontal occipital lobes, more confluent abnormalities along the frontal and parietal lobes. Again, you can appreciate the temporal abnormalities on the last image on the left. So the posterior fossa was relatively spared in terms of signal changes in diffusion abnormalities, cytotoxic edema, but the major findings are in the supratemporal brain. GRE did not demonstrate any significant hemorrhagic foci or mineralization. Some degree of venous stasis in deep medullary veins, but other than that, nothing very significant standing out there. Corpus callosum for a 7-month-old is slightly hypoplastic, but I think not significant as for this presentation. Brainstem, the hypon is slightly hypoplastic out there. On the contrast, you could not appreciate a significant leptomeningeal enhancement. These are the non-contrast plane sequences, and you can see that the CSF is not clear in the basic systems, even along the cranial nerves. Some degree of exudates out there in the system spaces. If you also look at the temporal lobes out there in the anterior temporal regions, you can appreciate that the submural space is not clear. Non-contrast T2 axial along the intercerebral arteries, arteries demonstrates these areas of thickening. This is not a vessel wall image. This is a T1 flare contrast sequence. Again, you can appreciate some degree of vasculitis in the internal carotal arteries. And then I think with Jaya.
So when the child presented to us, she had sepsis. The platelet count was just at the borderline. She had a hemoglobin of 7.8. CRP was raised to 210. The procalcitonin was high. Ferritin was 134. And so the before that, the blood culture was done. That was suggestive of Streptococcus pneumoniae. We gave her treatment with antibiotics, and then we went forward. After the MRI, we did the 2D echo as well as carotid Doppler. Both of them were normal. Then on the 8th day of illness, child had anisocoria that we noted, and CT scan was done. CT scan showed diffuse cerebral edema with white cerebellum sign. Prognosis explained to the parents, but unfortunately they took the child. They left against medical advice, and on the 9th day of illness, the child died.
So I don't have the CT images, but I think it has progressed into a severe excitotoxic brain injury, I guess. But the question was, Prithika, is this only infection-related changes or anything else?
Can anyone having an experience with Streptococcus pneumoniae leading to bilateral infarcts, and what could be the causes of bilateral infarct in this child? So is this only
I think
leading to?
Yeah.
Oh, sorry, I got intermittently. But anyway, thanks. I think the moment you pick up bilateral asymmetric white and gray matter involvement, I know it's quite acutely restricted. The commonest etiology driving this process would be infection before you get to anything else. So it's not a surprise. I can see some people have put comments like alert and AESD, and nowadays I don't understand those terms anymore. We just describe what we are seeing.
Well, these look like infarcts. So, I mean, not typical of alert. They look like typical territorial infarcts, at least the left side.
And I think what you were showing on the post-contrast flare is quite relevant in terms of, those things are very relevant to the infective process.
This is a non-contrast flare.
Even then, what is the highlighting?
Yeah. No, I'm highlighting the system. I mean, there's some process going on there in the system too. But it is not clear. Though it does not enhance clearly, but there's something abnormal out there.
Are you sure it's non-contrast? Because the mucosa of the nose seem to be enhancing in that one from the bit that we can see. I don't know what that sequence is, frankly.
I think it's a flare. I mean, this child only had a T1 contrast. Yeah.
All right. Okay. That mucosa is a bit bright too.
I think just in general wanted to understand, because this is a medium-sized vessel infarct, which we usually do not see in infective etiology. We commonly see small vessel or perforator vasculitis commonly. Just wanted to understand experience from other people as well. And is there anything what we could have done?
Yeah, so pneumococcus, it causes this. It's a bad meningoencephalitis.
But
I had a 6 weeks old baby, and
yeah,
8 weeks old baby once, and a 2-year-old. And if there is a delay of treatment, this is what you get with it. Very bad meningoencephalitis with strokes, infectious stroke, medium vessel.
yeah.
How old was the child?
The amount of exudates are not very prominent, if I'm not wrong.
No, exudates are there, Dr.
Exudates, yeah. I mean, they
Yeah.
are there, but normally yes.
Sorry, yeah, go ahead.
The same thing. I mean, it was slightly disproportionate. The reason why I wanted to discuss this case is, and commonly we see exudative process commonly either in pneumococcus bar tuberculosis. These are two common etiologies what we see. Causing thick encasing or thick exudates encasing the vessel can cause a major vessel clog. That's one of the described this thing, or intimal vasculitic, infective vasculitic process. But when we reviewed the literature as well, commonly small vessel vasculitis is described. Medium vessel is also described. But yeah, I mean, very uncommon. I mean, this is just another case, second case, which I'm seeing in my whole last 10 years, causing a medium vessel stroke, that too bilateral, following the pneumococcus.
Yeah. But there is, I think, even enough.
It's not unusual. I'm surprised you say that. And as mentioned, it's the vasospasm which is the culprit often, and it happens. Pneumococcal bad meningitis. Was the child immunized for pneumococcus?
No.
Okay.
Yeah, is the carotid arteries walls are hyperintense? Is it enhancing in by any chance the skull base?
I think
unlike in adults, this can be a normal finding because of vasa vasorum, but in children, I think vasa vasorum is still down. So this may be a large vessel arteritis which has produced.
That evidence is there. These two images highlight that at least they are arteries. This is a non-contrast one. The other two are contrast, but not vessel wall imaging. This is a flare contrast. So I think there is some degree of arteritis in the bilateral carotid arteries, which has led to the stroke. Well, it is contributed partly to the stroke.
Sure. And any other treatment modalities apart from antibiotic anybody has tried, which can salvage the situation?
There's a comment from Nargis of aspirin has been recommended in bacterial meningitis.
And this child, within 24 hours of doing an MRI, this child went on to have a massive cerebral edema, and
the child actually came to you after 5-6 days of the infection, so probably that's why the time had gone. But I had been giving dexamethasone in all my patients of meningitis for a few days. Somehow I feel the inflammatory process needs the dexamethasone.
Okay. I mean, with that sort of CRP and procalcitonin,
I'll still give it with the antibiotic.
Okay, sure.
These days with herpes, you give it. In herpes encephalitis is standard of care.
Correct.
Even though it's a viral infection.
True. Okay, sure.
Thank you. Thank you. Dr. Ek, over to you.
Am I audible? Sorry.
Yeah, no.
Okay. So this is a 10-month-old baby who had normal birth, but parents had noted that he always had significant delay with motor being more involved than the cognitive aspect. He had truncal hypotonia, had hypertonicity with a mix of dystonia and spasticity, mostly more in the legs, the spasticity was. He did have decreased facial expression, which sort of made us overdiagnose that he was more cognitively affected, but I think it was more of a motor syndrome with the significant hypertonicity. So we did his MRI, and after that we did his blood ammonia lactate and homocysteine, which were normal, and we did a TMS and urine GCMS, which was normal. There is no, his hearing is normal and his eyes were normal on examination, opthal examination. So Nihaal, do you want to discuss that?
Yeah, so the MRI predominant changes again in central regions of the brain, bilateral dorsal striatum, and also some aspects of the globus pallidus. So bilateral basal ganglia abnormalities, but relative sparing of the cortex nucleus, some degree of hyperintensity or diffusion changes on the midbrain out there. And on the ADC sequences, you can appreciate central area restrictive diffusion abnormalities. On the T2s, you have you have these hyperintense abnormalities in the basal ganglia, predominantly in the putamen and the globus pallidus, with some areas of sparing, or it is predominantly in the peripheral regions of the putamen. And along the again, there is some degree of hyperintensity in the midbrain. Corpus callosum is slightly thin for a 10-month-old. Again, you can appreciate the brainstem abnormality, slightly hypoplastic pons. I'm not sure if, I don't think we have an axial, but I could appreciate maybe there's some degree of edema in the cord also, especially over here in the cervical cord. The basal ganglia abnormality is not demonstrating abnormal mineralization or hemorrhage. Then thinking of the primary changes in the basal ganglia, these are the differential diagnosis. One can think of, I don't think a spectroscopy was done. So mitochondrial organic acidurias, biotin-thiamine responsive for the whole spectrum. So these were the, at least on the imaging, what one can consider as the possible differentials. Yeah, Dr.
No, they revised the report.
No, I put that in. Yeah.
So this one is not valid anymore.
Okay.
So
Okay.
so
So
the next one.
yeah. So as Dr. Mankal mentioned, PD-10A. Yeah, this is PD-10A also can have basal ganglia abnormalities.
So I went back to them when they sent. So I told them, is there anything else which could be there? So reviewed the data, and then they came with this homozygous mutation in HTRA2. But the thing is, there are two things. The urine organic acid was normal. But again, what I did was just a screen with TMS and urine organic through the filter paper, which is not the ideal way. I'm going to call the family and take a proper large amount of urine and send for just GCMS, which might tell us if there is 3-methylglutaric so the present screening didn't show it. And you know, the McDel is due to SERC2. So in the HTRA2, I don't think these MRI changes have been reported.
Not, I mean, at least on the OMM, I can appreciate atrophy and corpus callosum.
So yeah, so all of the 3-methylglucochronic,
yeah, these are
you know, there are so many types. So is that SERC2 gene, the McDel, which one which shows those changes?
Yeah, this is the typical changes. Yeah, now McDel.
Yes, and this is not McDel.
Yeah, this is not McDel. HTRA2 has at least to date have been described only atrophy and enlarged ventricles in corpus callosum as the main findings.
So I don't know whether it is the right reason if urine methyl, because already TMS with urine GCMS screen is normal. They did give these two genes before, the one you showed before, and but they didn't match. So I'm not sure if urine methylglutaconic acid, if I do it properly, if it comes normal, that I have the answer, because I did mitochondrial sequencing as well, which was normal. So both the nuclear mitochondrial genes for the mitochondrial disorders were covered, but obviously mitochondrial we often don't pick up.
Can I just mention that the putaminal I in McDel is stage specific or stage confined. It's not there initially, and it's not there in burnout cases.
Right, but again, that is in the specific gene, right? SERC2.
SERC1, I think.
SERC1, yeah, that gene.
Yeah.
So that particular gene is the putamen sign.
Yeah.
So this is so McDel, I think there are 5 or 6 variants. So this is a different one. So this is the problem with the genetic studies, where initially they had disregarded this one. Then I went back to them, so they gave me this report. So yeah, if urine methylglutaconic comes normal, then I have to probably say that this is not the cause, maybe.
Yeah, it's open for comments if anyone wants to add anything.
So your next step is to repeat the organic acid and to look at the parents. Am I correct?
So, yeah, I'll do the urine, but looking at parents is of not much use, right? Because they will come, even if they're heterozygous, it doesn't help if it's not matching. Because the child is homozygous.
Okay.
So it won't help. The help is more in patients where you have an autosomal dominant disorder and you have a heterozygous variant. This one is autosomal recessive, so parents are likely to have a heterozygous. So I think urine GCMS.
Yeah, urine GCMS I think is to be repeated. At least imaging wise, findings not described, but wouldn't rule it out.
Right.
Okay. All right. The next case, correct?
So this is I haven't seen the child actually. The family just came to me with the records 2-3 days back, and so whatever I have is from the history, which is from the notes and what the family gave me. A 9-year-old boy who was well before, and 5 weeks back, he suddenly became unwell with high-grade fever, multiple brief seizure over the next 48 hours, and that was treated as dengue, but again, NS1 was negative, IgM was positive, which can be an anamnestic response because the other markers didn't show it. The platelets didn't decrease, liver function was normal. He improved over the next 7 days, and then he developed severe headache and vomiting. And then at that time, he had his first MRI brain. And at that time, CSF had shown mildly raised proteins. His ESR was 90, CRP was slightly raised. And then he had 2 further CSF following the treatment. He was treated as acute bacterial meningitis. Nihaal will show the MRIs. And subsequent CSFs were normal. But over the last 5 weeks, child hasn't improved. He continues to have fever. And for the last 2 weeks, he started to have temporal semiology, multiple seizures a day. Even though in between seizure, he's fully conscious and talking. So his fever continues, his headache and vomiting has resolved, but he has seizures and fever. Based on that MRI, he was treated initially with the meropenem, and then, they, I think, thought of acanthamoeba on the MRI, so they started him on Ceptran and M4B. Then tubercular treatment was also given a small dose of steroids, so people are not sure what the illness is. So, and I'm not sure either. These 2 MRIs are in 3 weeks apart. So one is from 4th of November, which is 10 days into the illness, and the second one is just 3 days back, which is 4 weeks into the illness.
Okay. So the first MRI diffusion, first these scans, images out there, you have multifocal lesions with central areas of restricted diffusion, bilateral hemispheres involving the gray and white matter structures, but predominantly along the peripheral regions of the brain. On the T2 sequences, some degree of volume loss in the supratemporal brain, but again, multifocal abnormalities, peripheral areas of T2 hypointensities, possible hemosiderin deposits out there, and significant perilesional edema along the lesions. The posterior fossa did not have any abnormalities, but yeah, predominant changes in the supratemporal brain. The SWI sequences demonstrated multiple areas of blooming foci, again, predominantly in the peripheral regions of the brain of the lesions, but extending internally. Possible some projections out there, especially in the lesions along the left temporal lobe. So again, the sagittal images, the better demonstrate the extent of these lesions, the morphology of the lesions, not well circumscribed, but have peripheral areas of T2 hypointensities which correspond with the hemosiderin out there. Post contrast sequences, you can appreciate there is multiple, not well circumscribed ring enhancing lesions, but yeah, predominant pretty peripheral enhancing lesions in the bilateral cerebral hemispheres. So the main findings are these areas of distributed diffusion in the central areas with peripheral areas of hemosiderin deposits, and on contrast, there is peripheral enhancement. I think the follow-up scan, I think 11 days into the illness, after the first scan, again, multifocal abnormalities.
3 weeks of M4B.
Got it. But I don't think any significant improvement, at least in terms of these lesions. They still look the same. I think the edema is slightly increased. So, yeah, so in terms of the
Did we
lesion,
biopsy the lesions?
So yeah, that was my plan. That's why they didn't come back to me.
so the main differentials are fungal, I think, based on the initial sequences, at least the primary differential. HLH, I'm not sure it has these multifocal abnormalities associated with it. Posterior fossa pairing is slightly atypical. So HLH might not be in the prime differential diagnosis on imaging, but fungal infection is like possibility. Amoebic encephalitis. Not sure of the hemorrhagic foci. They are known to be associated with hemostatin foci, but they usually are very sick patients. Is that right, Dr. Vivek? The acanthamoeba or the amoebic encephalitis related
I've
to.
never diagnosed
Okay.
one.
Okay.
So I only
Okay.
heard in this
We had
forum.
one. We had
Yeah.
one. Yeah, we had one case previously, but the child was very, very sick. So I think thinking of infection, fungal, TB, I wouldn't consider TB as the first differential. They do not have those significant hemorrhagic foci initially, at least. I don't think spectroscopy was done. So yeah, we're looking at fungal, I think, primarily as the first possibility.
And
So I'll open the case. Yeah.
And you mentioned CNS HLH posterior fossa. Is that not for primary? Secondary HLH also should have posterior fossa involvement?
Yeah. I mean, they should, but typical being typical, you don't have these multifocal abnormalities presenting in the brain. So
right. So he did receive M4B for
so M4B
obviously
probably,
he
I
might
mean,
need voriconazole. I've requested
may not
for
actually treat a lot of fungi. Aspergillus would be inherently resistant. Few species of Candida would be resistant to AMPHO, and they'll be only sensitive to fungins.
Yeah, so voriconazole I had suggested. So, and galactomannan in blood, if that is of any help. So, and brain biopsy, these three things I suggest.
Dr. Nikhil, if I'm not mistaken, we had one case recently, aggressive treatment for 2 weeks, but still there was no improvement. The CVJ lesions. Are you aware of that case? So we similarly had a fungal case, I think last week over here.
Yeah. I think that child had a very chronic illness. There was some Aspergillus species which is inherently resistant to AMPHO and lot of other things. This child had received appropriate antifungals based on PCR characterization. So, and then child responded, including fungins. Yeah, but I mean, AMPHO may not be sufficient enough for treating fungal. And we recently had another fungal case actually. That was another Candida auris. That is also resistant to amphotericin B conventionally, inherently. This child had some genetic syndrome. I don't remember the gene name, but they're inherently this thing. I mean, they are prone for having fungal infections and neuromucosal candidiasis as a genetic predisposition, and they can spread. I mean, they conventionally what we see in fungus is they are very angioinvasive and they progress very rapidly. But this child almost was unwell. Very similar case, was very unwell, and he almost died 1.5 to 2 months into the course because of slowly progressive nature of his lesions.
This child is somehow not that unwell. His fever though continues, but seizures occasional. He's eating, but I'm sure. So in such cases, would you always go for a brain biopsy if possible? Is that the right approach, or is there any other way like blood galactomannan, or because they're not that?
In CSF galactomannan can be thought about.
CSF galactomannan is not a
that
good
would
test.
be more specific.
No, it's not a good test. BD,
I mean, the standardization
is in the serum.
Sorry?
It's in the serum, the blood. Galactomannan standardized in the blood.
Commonly, what we do is in serum. But many other Aspergillus derived antibiotics would be contaminated with galactomannan galactomannan. I mean, the galactomannan may come positive because of impenum groups. So those are the specific to fungus. If the levels are borderline, we cannot differentiate whether it is antibiotic induced versus fungus. I mean, yeah, aspergillus, which is causing the positivity.
Yes, Dr. Sorry.
The diffusion in the first part, it was centrally not restricted. It was mostly peripherally restricted with the hemosiderin. There was a central area which is not restricted. And also enhancer scan, if you carefully see, there is a thin ring along with subtly enhancing projections in. It's very classical for a fungus.
Fungal, yeah.
Okay.
And doing a biopsy, whether it's a contained fungus, so doing biopsy will make it a more meningitis, and we have a lot of patients after doing biopsy for funguses.
So avoid biopsy.
Probably with other antifungals we can treat, because I'm pretty sure that is a fungal disease.
Right, right.
All right.
Thank you.
Thank you. Okay, to our next case, to Pune, Krishnapriya, if you're there.
Good evening. This is a 6-year-old male child with normal birth and transition, normal development, and good scholastic performance until recently, with a negative family history. At 10 months of age, he had one episode of simple febrile seizure, then another one at 2 years. After that, the child has been developing normally. He is going to first standard, and his scholastic performance was good. At 6 years of age, recently, he had a febrile prolonged status epilepticus, which was controlled with 2 drugs. And following that, EEG was abnormal. It was showing excess slowing during the awake record as well. So a neuroimaging was done. And recently, he has lost a few. There is a little regression in his language, and he's not able to write the entire alphabets which he was doing previously. So the MRI.
Okay. The MRI into what is the duration from the MRI and the seizures?
It was 3rd day.
All right. Diffusion in ADC sequences. Confirmed abnormalities predominantly in the peripheral regions of the brain. Subcortical regions demonstrate areas of restricted diffusion. There is some degree, there is central sparing out there. So diffusion changes predominantly in the frontoparietal regions. Subcortical white matter, some degree of deep white matter involved, but predominant changes are in the frontal and parietal regions, and some degree in the temporal regions out there. Flare sequences, you can appreciate the edematous changes. The cortex also demonstrates some degree of edema, predominant again in the frontal and parietal regions. I could not appreciate any structural abnormalities, so the edema can mask that, but nothing significant standing out. No abnormalities on the hemosiderin, on the sensitive CX scans, or no mineralization. So given the imaging appearances and the clinical presentation, thinking of ALARD has this typical pattern of subcortical diffusion changes. Central sparing ALARD is what I'm thinking of on the imaging patterns. I think urea cycle disorders was raised. Is that right, Krishnapriya? As a possibility?
Yes, sir. Because the pattern was symmetric, and but we did a basic metabolic profile for this child. All of that ammonia, lactate, everything came back normal.
Yeah. So urea cycles, there's I think at least what I have experienced is the urea cycle usually have a cortical involvement of diffusion abnormalities, whereas the ALARD usually has a subcortical involvement. So if you see the examples out here, these are all cortical areas of diffusion changes, and usually present in the earlier stages. So 6-year-old child. So I wouldn't put urea cycle as the prime consideration. Imaging wise, the ALARD, as Dr. Mankad mentioned, what is the ALARD? What is the spectrum of disorders which come under it? I think epilepsy-related disorders changes would be the best description. Developmentally normal, I guess, Krishnapriya?
Yes, he is developmentally normal, but after the seizure, he is having a little regression of the language and cognitive milestones.
Yeah.
So we are wondering if.
Yeah, good evening. This child has not yet completely recovered. Like, this is now almost 1 month. And So we are of course planning to repeat an MRI. So are there
Yeah.
any other differentials? Because alert children usually either become very bad or they improve. I mean, one of the two courses they take. So 1 month lingering on with the cognitive deficit, we thought whether, you know, he went into some kind of a crisis, metabolic crisis, and so any other differential?
IL-6 cytokines tested, Dr. Shweta? Interleukins.
No, we did not do that.
Okay,
We did
okay,
not do. And can these be explained by the prolonged seizure itself? Because he did have a prolonged febrile status.
Yeah, I think there are seizure-related changes, but we are open to any further comments. The LARD type pattern.
And why does it have central sparing? Because I mean, if it's a cytokine related injury, the cortex is not any different in this area, right? Any explanation is there for that? I mean, any of the experts?
Dr. Kamte is the prime authority, I think, for the LARD type patterns. But yeah, I have not come to a explanation for the central sparing. There are two types, which you know, central sparing and the diffuse. And central sparing, sorry.
I've been seeing some of the LARD, I think, Dr. Nihaal. We have almost 3 or 4 cases in this given month, and only one of them could recur a little reasonably quickly. But others, in fact, one child was so bad. I mean, the recent one, I think we did that MRI day before yesterday. Yeah. I mean, she was completely ventilator dependent. She was in hospital for close to 3 weeks. We couldn't extubate her. Twice extubation failed. Very similar MRI in the beginning. And then that progressed to have further edematous changes all over, including the cervical cord as well. So these are all recently off late we are seeing they're taking slightly unusual course. But even the longer, the children who are taking long time, they're improving over a period of couple of months. We have had one big girl, she was, I think, if I'm not wrong, 13 or 14 years. She took almost 2.5 months to recover back to normalcy.
Okay, thanks. And did you find any specific viral etiology in these patients?
No, none of them we could find anything actually.
Yeah, same here.
Yeah.
Some of them are known to have genetic predispositions. The SNCN1A variants, I think. SNCN1A TLR3s. I'm not sure if the genetic ones are worse than the ones caused by the viral infection.
I don't think so. We are commonly screening for any of them for genetics. I think majority we are not screening. So,
Dr. Vivek, do you have any experience with genetic screening in these patients?
ALRDs, these are not ALRDs, sorry. These, I just seizure associated damages.
Yeah, but
I've done,
this pattern looks quite,
This pattern looks quite?
I mean, this pattern is like very characteristically coming in these subgroup of patients. So is there any association? We have not like screened till now, but have you got any genetics done and did you find anything?
No, I haven't done ever. But again, as Nihaal mentioned, people have done the genetic studies, especially the calcium channel and a few others which have been. For me, again, Eugene has always mentioned he doesn't like the term cytokine storm, you know, and agree with him in this issue here, because what I've seen, if the child presents in the first 2 years with seizure, he gets hemiplegic, HHE, where there is unilateral hemispheric similar damage. And somehow when they present between 2 to 8 years, they have this bilateral damage. So I'm not sure if this is a cytokine storm or this is febrile status related injury, which has been given various names. Like this is just my feeling.
And what is also intriguing is that some patients, even with such kind of picture, improve very quickly, and some of them, you know, even are difficult to extubate. And like this child is in somewhere in middle, like he's just persisting with cognitive deficits. came out quickly out of the ventilator, but has lost some language milestones as well as writing skills and so on. We are yet to repeat his MRI.
This peri-Rolandic sparing, has it got something to do with the peri-Rolandic collateral circulation development? Has it got any vascular etiology in this? Because the virus is inciting any vasospasm or anything. Why that peri-Rolandic sparing in some cases?
Yeah, same question I was asking. Like,
so peri-Rolandic sparing can be seen in some cases of hypoxia, basically when that collaterals are developed better. In the neonate, especially in the preterm babies, this peri-Rolandic collateral circulation between AC and MCA, it can be still a watershed. But when this in the term baby, that these collaterals between the anterior circulation and the posterior circulation is full, this area will no longer become a watershed. This is a protective mechanism for probably to spare the motor and sensory cortices. So if there is a vascular etiology, without a vascular etiology, how can the virus spare the peri-Rolandic cortex? I don't understand.
And this certainly looks like a vascular etiology more with this type of changes. And Bijoy, do you feel you have seen this in the first periods, the HHE? You know, the HHE is the same hemispheric damage, which is seen bilaterally in this age, you know.
Yeah. I think some this thing, hypoxic injury also we have seen, especially with the non-hypoxia in babies. So when the peri-Rolandic, the explanation for that was when this in the preterm babies, the collateral flow is not completely developed. We thought that is the cause. I'm not very sure about that, but the same pattern can be explained by vascular etiology. So whether it has got any vascular underlying explanation.
And this is at the watershed junction, right? Isn't it? It's very sort of watershed.
It is not the typical watershed for even for the preterm babies or this thing. But there is peri-Rolandic area which has got which will be spared. That's a protective mechanism. When this the microcirculation around this motor cortex and sensory cortex is, there is significant cross circulation developing, and that develops only after some time. It is in the extreme preterm babies, it may not be there.
But in term babies with acute severe asphyxia, we do find bilateral peri-Rolandic area affected. In fact, what we call as Broster-Rod syndrome, when they come with the CP, which is predominantly affecting the speech and, of course, with the mild diplegic kind of CP. So that cannot be explained by a watershed.
Always the basal ganglia which is involved, and some cases it is never involving the motor cortex and the occipital lobes. So it depends on the severity also, no?
Yeah. So acute severe asphyxia only I'm saying. So many a times there is only bilateral peri-Rolandic affection, hypoxic injury. So it may be likely that, as you suggested, that it is a watershed area. That's what I was trying to say.
No, we have seen definitely the corticospinal areas as well as the visual area, which is metabolically more active. If there is no collateral support, it is likely that these areas will be affected earlier by hypoxia. But some cases we have definitely seen vascular injuries, these areas, at least the motor sensory cortex being spared. This protection is not there for the occipital lobe because it has got a single circulation.
Okay, Dr. Kavita, maybe once you get a follow-up scan, we can see that what are the changes. Yeah. But yeah, we're looking at not a metabolic, or I think that was the question, I guess.
Yeah, because our radiologist suggested that it can be a urea cycle defect.
No,
so that's why we wanted to.
Okay.
Sure.
Right. Thank you. Happy to appear.
This is a 3-year-old boy with normal birth, transition, and development. There is no significant past or family history. He presented with complaints of pain abdomen for last 8 days, followed by lethargy for 1 day. And he developed a focal onset to bilateral status epilepticus. The clinical findings are not examined properly as the child came in status and the child is still on ventilator. but stroke was suspected and a 2D echo was done, which showed a pedunculated mass in the LV wall. It was reported as likely myxoma, but rhabdosarcoma was also considered. The child does not have any neurocutaneous markers on him. USG abdomen showed shrunken kidneys. He has CKD, which is detected only during this admission. MRI at admission was done, which showed acute stroke, and follow-up limited study was done after 48 hours in view of tight posterior fossa, which was showing kinking of the brainstem, both studies.
Okay. So this is the first MRI? Or sorry, I think there's only one MRI. Okay. So the MRI, you can appreciate again, we have infarcts in the posterior circulation, left more than right. Also some areas in the thalamic region, but they also come under predominant posterior circulation. Some degree of set punctate lesions in the frontal lobe, cingulate region out there. The predominant changes are in the posterior circulation, the brainstem, the vermis, the bilateral hemispheres that demonstrate these areas of multifocal infarcts. SWI sequences, I could only appreciate hemorrhagic foci in the vermis on the right side. No abnormalities in the supratentorial brain. There is edematous changes that is pressing onto the brainstem out there. So the posterior foci is slightly tight. The CSF spaces are slightly effaced. On the angio, I only had MIP sequences. I could not appreciate any focal stenosis, thrombosis out there. The neck vessels are slightly tortuous, but again, no flow-related abnormalities or at least significant stenosis. Post-contrast was done. Again, we could not appreciate any significant enhancement, at least in the meningeal region, and also in the areas which were involved. I think the question was, is this an embolic stroke and anything else, Vishnupriya?
Yes, why the selective affection of like entire one side if it's an embolic stroke? And is this LV myxoma causing an embolic stroke so common? Is there any other?
But it's there on two sides, no?
Actually, it is a bilateral.
Yeah.
Only thing was why it is predominantly in the posterior circulation. And but though there are a few, we can just go to the first slide.
Yeah.
There are a few areas of diffusion restriction even in the anterior circulation there.
Yeah. Yeah.
But predominantly the posterior circulation is affected. So is there any correlation? I mean, is myxoma known to cause such kind of cardioembolic strokes, mainly in the posterior circulation? That was one question. Because myxomas are anyways not that commonly seen in children.
In pediatric, yeah. No CVJ abnormalities to cause, I think, Bohanter's types of abnormalities also. But they are usually posterior circulation. Even that there are foci of anterior circulation too. Was Dr. Nikhil asked, is there endocarditis on the echo?
No, it is
there is no
actually a
evidence
huge
of
mass, but yeah, there's no fever also.
There is no fever. The cultures are have come as negative blood cultures, but there is CKD and the child has hypertension. The BPs are very high. He's on multiple medicines for the control.
Okay.
We actually came with a very raised ICP, maybe because of that huge cerebellar stroke and causing edema and very tight posterior fossa. So we actually approached our surgeons to do a decompressive craniectomy, expecting more edema as time passes, maybe in the next 48 hours. But they suggested to repeat a scan, though there was a little increased hydrocephalus in the next scan, and there was quite a significant kinking of the fourth ventricle as well as compression of the medulla bed. The child's sensorium is so poor. He's despite being on ventilator, I mean, without any sedation, he's not having much of spontaneous movements or anything. So the prognosis appears to be quite poor, and so they are also reluctant to do any compressive craniectomy and all now. So on this scan, what would be the strategy to manage? So that is another question for the experts here. So we did start with Clexane, as is indicated for a cardioembolic stroke. Hello, am I audible?
Yeah, Dr. Kavita, you're right. Sorry.
So it's open for the house to discuss.
Yeah.
The
So
fact
what is
that
the
it
cause
is
for
both
his altered sensorium such significant? Because so there has to be pressure, right? CSF pressure.
No, we did not do any CSF, but
No, what
it
I'm
appears
saying,
to be a raised
the
ICP.
CSF
Yeah,
pressure because of the obstruction is causing the altered
Yes.
sense.
Yes, and there is even more ventricular dilatation in the next scan.
So crenectomy should be done.
Yeah, so now actually at that point we were quite enthusiastic about doing it. Now in the next scan, because this has already increased and there is even more kinking of the brainstem, as well as the child is not coming out sensorium wise after 48 hours also. So
But that might do, he might improve with the because that's his
decompression.
chance. Yeah.
Yeah, that's what we are also trying to. That's why we wanted to discuss and get back to the neurosurgeon that what is
Because
the
no other
consensus here.
reason can explain, cerebellar, the thalamus is not cerebellum involvement. It doesn't, it's often when the cerebral pressure, cerebellitis, cerebellar stroke, whenever you often see dramatic improvement in the child as soon as you do crenectomy. And often they put in a shunt and not do a crenectomy, which is like no, because that causes reverse herniation. So they should always do a decompression first and just wait. That might help.
Would you not expect more tonsillar herniation if you hypothesize that the cerebellar swelling is responsible? There is still some space at the base of cerebellum, no?
Yeah, at this scan, I think Dr. Kavita says that has progressed on the follow-up scan, which we don't have. Is it right, Dr. Kavita?
Progressed, I think, in the follow-up.
So in the next scan, there is some kinking of there is more forward compression of the medulla.
So there is a mass effect by
Cerebellum is
the
sitting quite
cerebellum.
tight, though there is no herniation as such, tonsillar or even supratentorially also. Like upward herniation is also not yet seen, but the ventricular dilatation is definitely increased, though there is
That I
no
would
ooze.
expect, yeah, because I think if there's kinking, the fourth ventricle will be effaced to supratentorial hydrocephalus. But do we have to wait for it to go down is the question before intervening.
No,
If there is
their question is that whether there is any point in doing it now as well,
Okay.
because it's already, what is the prognosis and all those things. So
No, this is the point.
I-
This is the
That's
point
what-
in doing
yeah,
it.
I think we might as well do it. Yeah.
His
yeah, so
pupils are
that's what
reacting.
his pupils are reacting. Yes,
Of course, then that's the
and
time.
yeah, so that's what
So-
we said that we'll discuss it and get back today. Whether it should be done, because
Just
we
share
ourselves had a
something.
discussion and we did definitely wanted to do that.
So I just want to share something. We had a child with Morg encephalitis 1 month back. Within 48 hours, he deteriorated and he had unequal pupil for 3 hours, diffuse cerebral edema. And we did bilateral frontotemporal crenectomy. And the child he was in altered sensorium for 24 hours, and we were now debating diffuse cerebral edema, unequal pupil. Should we do anything? And parents say, this is our only child. Whatever you do, you just save it. And we did bilateral frontotemporal crenectomy. And I had asked everybody, and people say this is of no use. And the child is dramatically better now in a month's time. We have to give them a chance.
Yeah, thanks. That's the reassurance we wanted.
One more thing, that both anterior and posterior circulation involved and the vessels are relatively okay, means that it is most likely a cardioembolic stroke.
Yeah.
So, or it's a septic embolism.
Embolic.
So
Yeah.
we have to the why most of the emboli will go to from the heart goes to the anterior circulation is only because the angle of the brachiocephalic arteries and the common carotids and how the vertebral arteries. Here vertebral arteries are very large and the brachiocephalic is as big as the common carotids. So there is all the chance that even from the heart they can go. So it could be either an embolic, this thing most likely embolic from the heart or from septic emboli. So these are the only two things. Another thing is that if you are doing decompression, we should not wait till the last moment where everything is completely swollen.
Yeah. So I think Dr. Kavita, I've got
Yeah, agreed.
more than
I mean,
enough. I
we are
should-
after
yeah.
that, after them only.
Yeah.
Yeah. Thank you.
All right. Thank you. All right, Krishnapriya, your last case.
Yeah, this is a baby, 1 month old. In the antenatal period, there was history of preeclampsia, but there is no polyhydramnios. Baby was born term with normal birth and transition. The baby was feeding well and active at home till day 21. From day 21, the child started getting multiple episodes of left-sided hemiclonic seizures, including the face, eyelids, and the left limbs, which was multiple episodes for 3 days. And the baby was admitted, and the seizures initially responded to a single AED, but later it has become drug refractory now. On examination, there is a hypopigmented linear striae extending from the vertex to the nose on the right side, not crossing the midline. There are no other neurocutaneous markers. On examination, there is no focal deficit. Tone is normal in both limbs. MRI was done suspecting a structural lesion because the EEG, which was done for the seizure, it was showing marked asymmetry. This is the baby, and that hypopigmented lesion is highlighted.
Would it come under the Blaschko lines, many chance?
Pardon?
Would it come under the Blaschko lines, following the Blaschko lines, or?
Yeah.
Yeah, it does look like that. Yeah.
So from the skull region up to the nose.
Yes.
Almost like a linear pattern. Okay. Saheli Roy has mentioned hemimegalencephaly before the MRI. I think that is the right answer. So the imaging, I have T2 axial images that you can appreciate. The right cerebral hemisphere, especially the posterior quadrant and the temporal lobe, is abnormal. You can see in the lower panel, there is a degree of dysplasia out there, almost like a megalencephaly type pattern, predominantly involved in the temporo-occipital regions and also some degree in the parietal lobes. Greater sparing of the frontal lobes. But you can see also the ventricle is slightly pointed out there, which is typical of the megalencephaly type pattern. Coronal sequences again better demonstrating the malformed brain out there versus the contractile normal side. What was the age? I think corpus callosum is slightly thin. Just forgot.
This is taken at the age of 26 days.
Okay,
26 days.
Fine. Okay, yeah, then it's fine. Again, T1s, you can appreciate the malformation, possible dystrophic calcification or hypermyelination, accelerated myelination in the cortical regions out there. So predominant right temporal parietal occipital abnormalities in the terms of malformations. So the question was, is it hypomyelinosis of ITO-related abnormalities or Nevis sebaceous syndrome-related abnormalities? But I think neurocutaneous abnormality can present with dysplasia, dysplastic hemimegalencephaly, and these are the common differentials. So the clinicians have to tell me if it is hypomyelinosis of ITO or is it a Nevis syndrome based on the dermatoconjunctival abnormality. But I think mTOR pathway and the should be evaluated eventually for this child. The case is open. Yeah.
Question here was whether the anterior and the frontal lobe is also involved, or is it mainly posterior only?
Up to here, I would say yes, but not the anterior aspect. Not yet, I guess. Predominantly temporal, parietal, and occipital lobes. Cingulate regions, posterior cingulate regions, but almost entire hemisphere. But frontal lobe is relatively better than the posterior hemisphere.
Okay, thanks.
I'm also in favor of nevus yarazone or epidermal nevus because this is a classical combination with hemimegalencephaly. I mean, it doesn't matter whether you call whatever you call it, the management will be the same. But hypomyelinosis ITO, I'm not sure whether this is common in the face.
Okay.
So this child will need epilepsy surgery later because seizures are clearly refractory starting very early. So somebody's asking, are there extra digits? So no, there are no extra digits. Only the skin abnormality is there. And the baby is otherwise quite active and even has developed social smile at the age of 2 months now. So we are just we sent to the epilepsy surgeon also, who has sent back that let the baby be around 7 kgs at least, and then we'll be operating. So we are trying to manage him with the drugs itself as of now.
Is there any point in using sirolimus in such baby?
It's actually a very good suggestion. If somebody is having refractory seizure with the mTOR pathway and before surgery, sirolimus or everolimus should be tried. Some of the patients do respond well. Most of them don't, but some of them do dramatically respond. I have a Sturge-Weber syndrome patient, 2 of them very bad epilepsy and episodes of migraines, a combination of both. And after sirolimus, there was more than 50% improvement. Many patients used everolimus, hasn't worked in TS, but in some it has worked really well.
So what some people, I mean, we did discuss that as well in one of the conferences, and some people suggested that best is to actually do the genetics and find out if it is a, you know, one of the rasopathies and tauropathies and all that, because there are now different drugs available for different pathways. But
the thing is, you
to give
might not
empirically
find it
sirolimus, yeah, that's what we are.
because it is often a somatic mutation. So
Yeah.
it has happened after the stage of, you know, like 4 cells have formed. And then if the somatic mutation happens, it is not in the blood.
Agreed.
So unless you take a tissue from the brain, you might not find it. So even if it is negative, it doesn't take you away from a one of those pathway disorders.
Agreed.
Because
Totally
often
agree.
the
So,
blood is negative. There's a somatic mutation.
yeah, but most of these nevus syndromes, they may not be really responsive to sirolimus. The epidermal nevus, linear nevus syndromes, they are, I think, somewhere around that pathway only, because that's very complicated. I don't remember the exact names. So there is some in the RAS MPK pathway only, there are certain genes.
See, the answer is hemispherectomy in this patient, because longer you wait, the response, the child is going to become autistic. He's going to lose his arm and leg anyhow.
Definitely, it will reduce his cognitive potential.
Basically, his cognition will go. So the answer is hemispherectomy if he's getting refractory seizures. But if they don't agree and they are not sure, then.
No, we had sent him. The surgeon has told them to wait for the weight of 7 kg, because he's suspecting it's anterior as well. So that's what was our question, whether it is, I mean, the surgery, I think the approach is different.
Yeah. I won't do colostomy. Somebody mentioned colostomy. Colostomy is more of a palliative surgery for, you know, the potential after colostomy is much less as compared to hemispherectomy.
Sure.
Okay. Thank you.
Thanks.
Rituja, if you're there, you want to present it? Thanks. Thank you, Dr. Kavita. Thank you, Krishna. All right. Yeah. Go ahead.
This is 14-year-old female child with the history of language delay with intellectual disability and presented with seizures. So on further investigation, there was found to be hypoparathyroidism with low serum calcium, high serum phosphorus, normal vitamin D, and low serum PTH.
Just to add this, child is from the Middle East. I'm not sure which country, but not from the Middle East. Yeah, go ahead, Krishna.
And on examination, child had short stature with microcephaly and subtle dysmorphism was present in the form of small palpable fissure with deep-seated eyes. There was prominent nose, prominent large dysmorphic ears. As we can see, there was abnormal dentition. And on limb examination, there was thin, slender fingers and the thinner wristing that is seen in this case.
Yeah.
There was also kyphosis that was present, and coloboma in the eyes with doubtful peripheral cataract was noted.
Okay. So then I think the child got an MRI and a CT scan done a couple of days back, suspecting parathyroid-related abnormalities. CT scan demonstrates these areas of intracranial calcifications in the cortical subcortical regions, frontoparietal lobes out there, parietal deep gray nuclei demonstrating calcifications, and also in the inferior cerebral hemispheres, we have these areas of calcific foci. So multifocal abnormalities, some areas of partial confluent calcifications in the subcortical cortical regions. On the MRI, to add to the calcification, supratentorial brain, there was no focal lesions, no significant atrophy, possibly some degree over there, but not very significant. The other abnormality which we found was the pituitary was hypoplastic. It was around 1.5 millimeters, which is significantly low for a child of 14-year-old. There was some degree of pontocerebral hypoplasia. The thinning of the anterior and mid-corpus callosum, slightly dysplastic out there. So coloboma was mentioned, but we could not appreciate any colobomatous changes on the eyes, at least on the MRI. So we propose a diagnosis of hypoparathyroid or parathyroid abnormalities, which can have the calcifications in these typical locations, the basal ganglia, the subcortical cortical regions, and also in the posterior fossa cerebellum. Child also had a skeletal survey. These are the skull examination, the lateral projection out there. There is some osteosclerosis of the fingers of the metaphyses out there. The chest X-ray, we could not appreciate any significant abnormalities of the ribs. Scoliosis was mentioned. Possibly there is some tilt over there, but not very significant. Yeah. And then clinically, the treating physician raised the possibility of Sanjay-Sakati syndrome. We don't have a diagnosis, but I would like to discuss this case if anyone has any experiences with this syndrome and related syndromes of the parathyroid-related abnormalities. So at least the described findings of the syndrome are it has hypoparathyroidism, hypoplastic pituitary, corpus callosum is abnormal, there is some degree of myelination abnormalities. They can have these various systemic features, dysmorphic facies, which I think some of the features are seen in our index case. Ocular abnormalities can also be seen. Intellectual disability is another feature, and they usually belong to the Middle Eastern areas. So if anyone has any related cases or experience, that would be helpful. Another thing, I looked at literature to see if there's a relation of parathyroid disorders with infratemporal abnormalities. I couldn't find anything. Maybe Eigen has any experience with PCH pattern with parathyroid abnormalities. So biochemically, it's proven of, I mean, they're suggestive of hyperparathyroidism. I think imaging matches. The only thing is you need to put the imaging and the clinical features together. The child has been sent for genetics. But yeah, we thought of discussing this case before we get a result. Okay, if there are no comments, I'll probably get back to you if we have a result on the genetics. Thank you. So this is a follow-up case. Dr. Vivek, if you're there, you can quickly go through it.
Yeah. So this is a case we discussed a month back. So just to summarize the history, it's a long history now, 3 months illness. This child was completely well before, and mid of September, he had an acute respiratory illness, which was S3N2 positive. And over a week, he worsened. He had brief ventilation, and they also had to give a brief period of steroid, and then he improved. And then 3-4 days later, he worsened again in form of focal seizures and suddenly developed brainstem signs in form of bulbar palsy, the downbeat nystagmus, and he was pooling his secretions, so had to be ventilated again for a period of time. And at that time, he had his first MRI done, which we had discussed before. This was his first MRI at the time. And I remember at the time, we were not sure what this could be, but a differential, and with the hemorrhagic changes, fungal infection, especially aspergillus, was high on the cards. His lungs at the time were also imaged with a X-ray and subsequently a CT, which showed pulmonary small aneurysms and collapse and consolidations as well. Toxo was also kept as a differential, but his toxoplasma serology was negative in blood. Galactomannan was mildly raised. So overall, we decided, okay, this looks more fungal, aspergillus-like. So we started on voriconazole. And ferritin was normal in blood, and glucan and CSF was normal. So over the last 6 weeks, he has received voriconazole, and on that he has shown improvement. His tracheostomy is still there, but his bulbar weakness, everything is better. But then few days back, he started to have focal seizures. So we repeated his MRI again this time after 2 months of that initial imaging. So this is his second MRI in a gap of 2 months. So initial illness, COVID H3N2 positive, followed by deterioration with brainstem signs. Initial first MRI was more suggestive of fungal query toxo, and 2 months of voriconazole finished. And he has some symptoms in form of seizures, but no fever for last 2 months. Child is eating, he's well, except for these seizures, because of which we had to do MRI again.
All right. So the follow-up MRI, let's see, let's quickly go through the first ones. Okay, I don't have the T2s, but yeah, they were multifocal lesions, hemorrhagic lesions, which demonstrated predominant peripheral enhancement with some internal projections, which pointed towards the possibility of the fungal etiology. Follow-up, I apologize, I don't have a T2 for the prior scan, but you have these, again, multifocal lesions now more circumscribed as compared to the prior study, reduced in size, but there is the edema, which is which I could not compare with the prior study. Again, multifocal abnormalities with hemorrhagic foci, more nodular now, possibly granulomatous lesions. And on post-contrast study, you have more nodular enhancing foci. Some have this thick enhancing foci, but in comparison to the prior study in September, there was more. The lesions have significantly reduced in size. Some have become nodules, whereas others have also circumscribed in comparison to the prior study. So the question was, I think Dr. Vivek was asking is this still a fungal etiology, or should we consider tuberculosis? Is that right, Dr. Vivek?
Yeah. Because if I had this MRI scan for the first time, I'll think of tuberculomas.
But again, if you had seen the SWA sequences, I mean, if you are thinking these are hemorrhagic foci, that would be slightly atypical for tuberculosis. I think the child has responded to treatment, hence the reduction in size with granulomatous formation. So,
but these, fungal abscesses and fungal granulomas take a very long time to recover. And are you doing their voriconazole levels? Because the dose has to be adjusted. We had one patient where we had to give it for almost 6 months, and his levels were very fluctuant, and we had to keep doing the blood levels to achieve those levels. Those trough levels are important. I think I don't remember exact level how much it has to be maintained, but our hemato-oncologist was quite persistent about it. And voriconazole itself is very costly. Then the levels are also costly. But without that, it's not optimum treatment.
His CT chest still shows the collapse consolidation. Like I asked our ID, and they said this looks more like tuberculomas now. So we had started ATT,
So in that child also, we landed up giving both. But
rifampicin reduces voriconazole levels to 0. So that's why they are saying you cannot commit to both.
Yeah, but we had to adjust the voriconazole levels according to the trough levels, and ultimately the child came out. So we still do not know what he exactly had, because he received both, and he in fact received second line AKT as well. Because in the bronchial aspirate that we did, because we did the bronchial lavage and all that, it was showing aspergillus. In fact, one of the videos which we got, it was showing all white membranes inside. So that was very typical to be supposed to be very typical for this aspergillus. And on the other hand, some of this thing was showing granulomas like tuberculosis. So in an immunocompromised child, we landed up treating both actually. He was a child who was on.
He was a well child before, you know.
Okay.
And,
no, this child of ours was actually on chemo for ALL. He had come out of it. He was in remission and he was on just maintenance treatment. And on that, he developed all these complications. But fortunately, he came out later. But it took almost 4 or 5 months of struggle. We were also very intrigued what it is, and we landed up giving.
Is Bijoy there? Like, is Bijoy seen such cases? Like, is this tuberculoma still for aspergillus?
No, I will not consider tuberculosis at all in this case. It is likely fungus or toxo, like I've actually discussed last time. Again, like Nihaal has told that there is these inside, there is these irregularities inside, which is also enhancing, and there's also diffusion restricted last time. So the fungus is the most likely diagnosis, given the fact that it has actually responded to some. And ATT, I don't think it is going to help. It is very unlikely to be tuberculosis.
Mm-hmm. Okay.
And child is not immunocompromised. Yeah.
No.
Yeah. Yeah. So, Dr. We agree with fungal, but clinically, I think you have to take a call.
Sure.
All right. I think that is our last case. So we'll meet again in 2 weeks' time on December the 1st, and kindly send your cases by the 29th of November. And hope to see some of you at SPIN Part 2, Day 2 tomorrow. Till then.
Nihaal.
All right. Thank you, Dr. Vijay. Thanks, everyone.